So today we're concentrating on what happens after progression on first-line chemoimmunotherapy. Traditionally, we have described patients as platinum refractory if they progress within 6 months of that first platinum-based chemotherapy, or platinum resistant if they progress after 6 months. And that has been a category that we have described because some patients, if they have progressed after 6 months, they could respond to platinum-based chemotherapy. I think that paradigm will change as we get better treatments in the second-line setting, and perhaps instead of trying platinum-based chemotherapy again, which patients already have progressed on, we may try different agents with different mechanisms. So before I get to that, we recently heard about the approval of the Lurbinectedin chemotherapy that was approved in the second-line setting, kind of in the same range as topotecan. But what if we add that treatment as a maintenance option for patients that finish their induction chemoimmunotherapy and then continue immunotherapy with lurbinectedin? So this was a trial called IMforte. It was a global trial. Patients had an induction of 4 cycles of carboplatin immunotherapy with atezolizumab, and only if they responded and had an ongoing complete response or partial response or stable disease, they were able to be randomized to a maintenance strategy of immunotherapy alone, which is what we usually do, or immunotherapy with chemotherapy called lurbinectedin. There was no crossover allowed in that trial. And I think the difficult thing with this trial is that a lot of patients, about a third of them, did not make it to that maintenance therapy. Either they didn't have stable disease or a response, or they were not fit to receive chemotherapy in addition to immunotherapy. So 7 patients never started treatment, and some patients had discontinued treatment at time of induction. So it's not an option for every patient. It's just for those patients who are doing well after the induction and can tolerate the addition of chemotherapy early in the maintenance setting. But there is a survival advantage to this strategy. And if you look at the progression-free survival for the combination of lurbinectedin with atezolizumab, there's a hazard ratio of 0.54, which means that there's about a 50% reduction in mortality or progression-free survival for these patients, with a progression-free survival median of 5.4 months versus 2.1 months. So there is a movement of the curves of more patients progressing later, although it's not a very dramatic response. It's still a positive response. And more importantly, there's an overall survival advantage to this maintenance strategy with a hazard ratio of 0.73. Again, for those patients who are fit enough to tolerate more chemotherapy early after induction, and the median overall survival was 13.2 months versus 10.6 months. So barely about 3 months of improvement if you do this maintenance approach for patients. Again, if you count the patients that had already induction, this survival advantage is probably even greater, because you have to take into account that these patients, that median overall survival was from the moment they started maintenance, but they had already completed an induction that took about 3.2 months. So these patients are doing better in their second year with this therapy. But it's not an option for every patient. There was a low effective crossover, so a lot of patients in the control arm never were able to get another therapy. And 63% of patients on maintenance went on to receive second-line therapy. So at least we know that some patients did get treated in the second-line setting, but some did not. And here are some of the side effect data. So this feels more like chemotherapy to patients. There was an increased rate compared to immunotherapy alone in the maintenance setting of nausea, anemia, fatigue. And fatigue is very significant, especially because this is an older population. Decreased appetite can also impact, obviously, performance status for these patients. But it's more a chemotherapy approach that we have a lot of drugs to manage. We have growth factors that we can help patients manage. So there's definitely about 5 times more grade 3 and 4 AEs, most of them related to chemotherapy cytopenias. But still, the discontinuation due to the drug was about 6.2% due to any of the drugs. So a little bit more than immunotherapy alone.